In this video, I will discuss reactive arthritis, also known as Retter's syndrome. So, reactive arthritis is a seronegative spondyloarthropathy. It means there is no positivity of ANA or RF factor, or also anti-CCP is also negative. It occurs after mostly infections. For example, gastrointestinal tract infection either caused by Salmonella, Shigella, Campylobacter, or genitourinary tract infection, for example, caused by chlamydia. So after these infections, this seronegative spondyloarthropathy develops. It is an autoimmune response and not a direct infection of the joints. So arthritis is due to an autoimmune response, not due to arthritis by a infective organism. Etiology or common triggers. As I have told you, chlamydia trachomatis causing genitourinary tract infection, or gastrointestinal tract infection caused by Salmonella, Shigella, Yersinia, Campylobacter, or E. coli. These all infections can lead to the development of reactive arthritis. You should remember that reactive arthritis is not due to directly infection of the joint, but it is due to an autoimmune response against these organisms. Classic triad. The patient has classic triad of can't pee, can't see, and can't climb a tree. Can't see, conjunctivitis. Can't pee, urethritis. And can't climb a tree, arthritis. So, conjunctivitis, urethritis, arthritis. First one is conjunctivitis and uveitis. Second one is urethritis. And third one is arthritis. Can't see, can't pee, can't climb a tree. Clinical presentation. Articular features. Patient has asymmetric oligoarthritis. Less joints are involved in case of this reactive arthritis. Mostly knees, ankles, or feet and shoulders, etc. are involved. There is enthesitis. Enthesitis means inflammation of the tendons and ligaments where they join the bones. For example, heel pain, Achilles tendinitis. Heel pain is also known as plantar fasciitis. There may also be dactylitis leading to formation of sausage-shaped fingers. Low back pain may also be seen. Extra articular features are urethritis, cervicitis, conjunctivitis, anterior uveitis, as I have told you, conjunctivitis and anterior uveitis leading to can't see. Mucocutaneous lesions are also seen with reactive arthritis, like keratoderma bilanoregica. Keratoderma, as the name shows, hyperkeratotic skin lesions. Hyperkeratotic skin lesions, these are present on the feet soles. Circinate balanitis, inflammation of your penis. Painless erosions seen on the glans penis. So circinate balanitis, painful erosions seen on the glans penis, mostly in case of chlamydia. Oral ulcers can also be seen, but these oral ulcers are painless ulcers. Investigations. You have clinical diagnosis also. So based on the history of the infection and then development of the arthritis leads to suspicion of reactive arthritis. Then what labs you should do? ESR should be done, and CRP. Because of inflammation, these both inflammatory markers are raised. HLA-B27 is positive in almost 50 to 80% of the patients, because it is mostly seen in the patients who are HLA-B27 positive. And then we send urine and stool cultures to identify the infection. Mostly if chlamydia is suspected, then we go for urinary nucleic acid amplification test, NOT, and it detects chlamydia. Synovial fluid should also be examined. So joint fluid aspiration should be done and synovial fluid should be examined. It should be sterile, that is, it should be culture negative, and also the inflammatory cell count should be no more than 50,000. So it should be less than 50,000, not reaching that limit of septic arthritis. Management. Treat underlying infection. If there is chlamydia trachomatis underlying infection suspected, you go for doxycycline 100 mg twice daily for 7 to 14 days, or azithromycin 1 gram single dose. But along with azithromycin, try to give injection ceftriaxone, so that if you are suspecting gonorrhea as well, then azithromycin and ceftriaxone both kill the chlamydia and gonorrhea both. Treat sexual partners as well. Symptomatic treatment. As patient has arthritis, so for arthritis you go for NSAIDs. NSAIDs are first line for pain and inflammation, and arthritis mostly remains for weeks to months. So this arthritis requires management. All other signs and symptoms disappear mostly within days or weeks, but arthritis remains. So NSAIDs are given for arthritis as first line treatment. Then if arthritis don't work, then we can go for corticosteroid injections into the joints, but it is not routinely recommended. You go for disease modifying therapy if patients do not respond to NSAIDs. Disease modifying therapy includes sulfasalazine and methotrexate. And if patients don't respond to these two drugs like sulfasalazine or methotrexate, then we can go for TNF inhibitors, tumor necrosis factor alpha inhibitors, for example, infliximab, etanercept, etc. So if the disease is refractory to the sulfasalazine methotrexate, then we go for infliximab, that is TNF alpha inhibitor. Physical therapy, joint mobility and muscle strengthening exercises should also be encouraged. Prognosis, it is a usually self-limiting condition. It resolves in 3 to 6 months. Mostly arthritis may remain for years. Chronic or recurrent arthritis is seen in 20 to 30% of the cases, and HLA-B27 positive patients are at higher risk of recurrence. So HLA-B27 positive patients are predisposed to the development of reactive arthritis and other spondyloarthropathies that are seronegative.